Hi, good morning. Good morning. Welcome. This is our final lecture of the academic year. And next week we'll have my semi-annual town hall to wrap up, and then we'll be off for the summer and pick it up again after Labor Day. It's our tradition to ask a particularly notable speaker to join us for our final lecture of the year. And we're really delighted to have Matthew Weissman here with us today. I've known Matt his entire career, and it's been a real joy for me to watch Matt as he's progressed along and all the wonderful work he's done in the places he's focused his attentions. Matt has got his BA in economics from Harvard College, and then his MBA and his MD from Tufts University, and then completed his internship and residency and chief residency in the combined internal medicine pediatrics residency at Mount Sinai, and has devoted his career to New Yorkers. He started off at St. John's in Yonkers, and then was at Ryan Nina for the house staff. Matt was the medical director at Ryan Nina for a number of years. And now in his current role is the chair of medicine as well as senior faculty in the departments of medicine and pediatrics at Mount Sinai, chair at Mount Sinai, Beth Israel. Perhaps his most important role prior to taking on the chair was as the chief medical officer, also the acting president and CEO of the Community Healthcare Network. And it was there that Matt really brought his talents and desire to match mission to resources in providing care to communities that we're all aware of and care about. For example, the trans population, women and women's health, and doing women's health with excellence in a primary care setting. HIV prevention, people struggling with addiction and bringing therapeutics to them at the site of primary care. For the house staff, for me, Matt is an example of excellence in what I think of as a physician executive track. And as you hear from Matt today, be thinking about that and how one can make an impact in healthcare as an executive, moving things along in ways that ultimately are most important for patients and their families. Matt, it's such a pleasure to have you with us today, and thanks for coming.
Thank you, Dr. Seward. Should we put the slides? They'll come up? Okay, good. Thank you for that lovely introduction. I mean, obviously, Dr. Seward is a big reason why I came here the first time when I did MedPeds residency, and then a second time when I came back about 10 months ago as chair at Beth Israel. So it's delighted to be invited today. Another big reason, look at that. Thanks, Billy. Another big reason I came back is this, which you may remember is an ad that the Mount Sinai Health System ran in the Sunday New York Times a couple of years ago that says, if our beds are filled, it means we've failed. And the small text at the top really talks about all the hard work that we do at the system outside of the hospital around things like population health and ambulatory care and care management. And those are really a lot of the things that drew me here, because those are really so important in all the hard work that we do. And when we look at what's happening at Beth Israel now, it feels like the future of the outpatient care, of all the stuff that's happening outside of the hospital, really is the future of the hospital at Beth Israel. Now, that's true throughout the system, of course. Here's our Gianelli at the ribbon cutting uptown at the Ambulatory Care building. And throughout the system, there are big investments being made in ambulatory care. In my local space, here's a couple. This is the primary care suite at 2G, just before we peeled off all the painter's tape about a week and a half ago, which has been great to move into there. We're renovating all the other specialty suites. Pulmonary got finished last year. This is the new Respiratory Institute downtown. And so every day I'm living in this world of unwrapping ambulatory care spaces at the same time as we plan for a new psychiatry hospital downtown and a new inpatient medicine hospital downtown. And as we think about those, we're thinking about outpatient care too, and we're designing rooms that have video screens with some sort of camera and artificial intelligence so we can get connections with the outpatient doctors and with the subspecialists, even from what otherwise looks like a pretty traditional hospital room. So my goal today is to talk a little bit about the environment of outpatient care as we see it in the health system, and a little bit, as Dr. Seward mentioned, about some of the places I've been and some of the lessons I've learned and how we can incorporate that into some of the work that we're doing. So we're going to digress just for about 10 minutes and talk about federally qualified health centers, which is where I've spent the last 10 or 15 years of my career, and where, you know, a lot of people training in our system actually get exposure to through the Ryan system, mostly, and a little bit at the Institute for Family Health. You know, I've somehow made it through medical school and residency, and my first job out, I never even heard of a federally qualified health center. So I always like to take a couple of minutes and just summarize some of the nitty-gritty. So there are really 4 key things that make something a federally qualified health center. One is that it gets located in an area of high need, so that's a medically underserved area that the federal government designates. That it has a comprehensive set of services, and that's beyond primary care, as Dr. Seward mentioned, things like behavioral health and dental and podiatry. That the board of directors actually has to be made up of 51% patients, and so it's a very patient-driven organization, and that it's open to everyone, regardless of insurance status or immigration status or English-speaking ability, which is particularly important in these times where we're all thinking about issues like that. FQHCs got started in my hometown of Boston in 1965. Jack Geiger, who was an activist and a physician, really led the way in kicking off this model of care. And then it becomes this real bipartisan model. So LBJ and Ted Kennedy were really 2 of the people who led a lot of the initial policy making, setting up FQHCs. But it was actually George W. Bush who doubled financing and really paved the way to increase the numbers of FQHCs across the country. You know, in blue states, it tends to be the urban poor that gets served by FQHCs, but in red states, for vast rural areas, FQHCs are really the provider of choice. So I wanted to look at briefly some of the stuff we did at Community Healthcare Network. This is a map as of about 6 months ago. They've opened a couple of new sites since then, with facilities all across the city, 5 medical mobile vans, including an ophthalmology van, and really a broad array of services, as we mentioned, things way outside what people normally think of when they think of internal medicine or primary care. I wanted to also highlight health homes because I think people get confused about that a lot. So remember, health homes is different from home health. It's a Medicaid-funded care management program that helps provide this sort of extended care management to people who are on Medicaid, who either have HIV or a mental illness or 2 chronic illnesses, which defines almost everybody that we see at Beth Israel and probably a lot of what you guys see here in uptown. Mount Sinai runs a great health home program. We spend a lot of time and effort trying to refer to them. CHN also did, and so it's a great opportunity to really broaden the reach of what we do in the exam room outside into experiences that they're having at home. FQHCs serve about 1 in 6 people receiving Medicaid, 1 in 6 rural Americans, 1 in 3 individuals living below poverty. So they really cover a vast array of society. And because they're federally funded in part, there's a lot of reporting requirements. And so FQHCs submit this UDS data every February to the federal government, both on clinical metrics and on financial metrics, which then get posted publicly on the website. So not only can every FQHC see how they're doing compared to all the other FQHCs in the country, but the public can go and look too. And that means also that there's this treasure people can mine to look at to see how FQHCs are doing, both in general and in particular. And what we see is, you know, better diabetes and better blood pressure control than all comers in the country, more preventive care services, and at a lower cost. And you'll see that every bar of this bar graph is smaller in the FQHC world. So they're not only decreasing the cost of outpatient care, but also the inpatient care and the ED care is less in FQHCs. Now, all this success doesn't come without its challenges, and I think the challenges are very similar to the things we see here and elsewhere. The biggest is a clinical vacancy. So about 95% of FQHCs are short at least one clinical person. And in 70% of the cases, that's a primary care doc or a family clinician. Lots of reasons for that, of course. But one of the things that we talk about a lot is burnout. And you've seen this graph before, undoubtedly. This is from JAMA from a few years ago, and it's shown at a lot of burnout talks. And I like to highlight a couple of things. One is that all our specialties, so internal medicine is right up there near the top, family medicine is right there. And so we see a lot of burnout in the areas that we work out of. But even in the sort of lower down specialties, the burnout rates are still in the like 30 or 40% rate, which is significant. So we spent a lot of time at CHN evaluating this. And one of the tools we used is the Maslach burnout inventory, which looks at emotional exhaustion. So how often do you feel burnt out by your work? Depersonalization, how often do you come home and say, I don't care what happens to my patients or what happens at work? And personal accomplishment, sort of the inverse of how often do you feel like you accomplished many useful things while you're at work today? And needless to say, we found a fair amount of burnout at CHN too, and for all the usual reasons. A big one, of course, is clerical burden that in surveys nationwide is the leading cause, which made us want to think about this quadruple aim. So adding to the better outcomes, lower cost, improved patient satisfaction, also providing an improved clinician experience. And that was highlighted in this paper by Don Berwick in JAMA a couple of years ago called Breaking the Rules for Better Care. And, he starts off by telling the story of a dean of a business school who goes on sabbatical and visits another place and checks in at the front desk and notices that everybody who rides a bicycle to work has to sign their bicycle into this bicycle logbook. And when she looks behind the desk, she sees that there are actually stacks and stacks of bicycle logbooks going back decades. And when she asks why people are doing this, nobody can tell her. And she does a little more digging because she's a resourceful person. And she finds out that this dates to World War II when there were fuel rations. And so people who rode their bikes to work and saved fuel would get extra food chits and could redeem them in the cafeteria. And so for 70 years, they've been continuing. No more fuel rationing, there are no more food coupons. But it was one of those things that people had been doing and never evaluated whether it made sense or not. And I dare say that happens a fair amount here and elsewhere in medicine. And so that led us to ask this question. If you could break any rule in service of a better care experience for patients or staff, what would it be? And we spent a lot of time asking this question, and we ended up forming a committee, the Transforming Administrative Burden, Sharing Knowledge, and Sustaining Change, or TASKS Committee, which was really a multidisciplinary group of folks who sat down to say, of all those rules that we could break, or all the things that we're doing now, which things really could be not done at all, which things could be done by some other staff. My microphone might have just died. Oh, good, thanks. And which things could be replaced by technology. And we came up with a long list of a lot of things you might imagine, Xeroxing extra copies of things and entering stuff twice. And then we really started eliminating all those things. This was highlighted again in a recent article by Dr. Ashton from the University of Hawaii in the New England Journal of Medicine just a few months ago, where they wrote an article getting rid of stupid stuff and basically asked nurses and doctors, what are all the stupid things in our EMR? And let's make a list and we'll just start, knocking things out. And what's shocking to me, first of all, obviously there are a million suggestions of things we could change. But only a very small percent, about 15% of them were deemed not possible. So the vast majority of things, were known, to clinical staff and where possible. And we saw this as like a real call to action at Beth Israel also, is like take stock of all the things that you're doing, and let's figure out how to make them better, more efficient, cleaner. Now, there's not a lot of data out there on how to do this. I like this AMA, maybe some people have seen the AMA SGIM combined on this Steps Forward website with a woman named Chris Sinski, who's sort of leading this charge. And there are a bunch of online modules for things around how to manage your EHR inbox, how to bring joy to work, how to implement change in your office. This is sort of my favorite one about why you should order blood work for before your next visit instead of after your next visit. There's sort of interesting little tweaks that you can make to your workflow that make your life a lot easier. And Mount Sinai knows this, and we've already started implementing a lot of these kinds of changes in the interest of improving clinical wellness. So, as you know, we named John Ripp as the Chief Wellness Officer, and there are department-level wellness champions throughout the system. And, some individual level interventions around, mindfulness and resilience, which are important, but obviously aren't getting at the issue of reducing the clerical burden. And that's sort of where epic optimization comes in. I just did my training a couple of weeks ago. And it's really interesting. There are epic champions at each site, and then there is formal epic training to figure out how to streamline your individual workflow so that you're reducing the number of clicks and increasing the number of predetermined phrases and stuff that you can use. Also some dictation software, and then one-on-one optimization where people will meet with you individually to talk through how to make your use of Epic even more efficient. And at the same time, there's some practice redesign that Stella Sappho and others are leading from Uptown, which is going into individual practices. The first cohort was last fall. There's another cohort starting soon. And really looking at individual practice flow and thinking through the sort of QI metrics and how are we using the flow through the rooms properly, how are we using Epic properly, and how are we, how are all the workflows going to really speed up what we do. And I will tell you, we actually weren't in this cohort, but as part of our move in primary care to that new suite that I showed you, we went through with the system strategy teams and thought through our entire workflow of how primary care looks and how we room patients and where they get their blood drawn and who's logged on to Epic where, and totally redesigned what we've done. I mean, it's only week 3, so it's hard to call it a success, but it has really changed the feel of the suite. It's way less crowded in the hallways. The waiting room is basically empty, and it's really improved a lot of what we do. The second most common cause for burnout is increased clinical expectations. And, at CHN, we saw this most commonly with our nurse practitioner staff. We hired about 60% doctors and 40% nurse practitioners at CHN for a bunch of different reasons. And what we learned quickly about nurse practitioners is that while all the studies show that their care of chronic illnesses is equivalent to doctors, when NPs graduate from school, only about 10% say they feel well prepared to provide primary care, and even less so in an urban, underserved community. And as a result of that, the turnover rate for NPs is way higher than our turnover rate for doctors, and we were getting sort of stuck. So we created a fellowship program, which in a lot of ways felt like my internship. I mean, it was preceptored outpatient sessions, and then a mix of subspecialty rotations throughout the community. And I may well be asking some of you for specialty rotations after this. And it created an opportunity for these board-certified licensed NPs who could have gone and practiced anywhere, but who realized these were the sort of the cream of the crop because they recognized what their limitations were. They were able to do a 1-year fellowship program and really learn the skills that they needed to have in order to be able to thrive in the urban underserved setting. And it was a big success for us. We ended up hiring a bunch and getting people hired other places. We got a grant to do this same sort of thing throughout New York State. We actually went on a big road trip and did workforce analyses at a lot of practices, both FQHCs and larger hospitals, to figure out how to use nurse practitioners to more efficiently fill out their workforce. So another big dissatisfier is the issue of no-show patients and how frequently that happens and how to reduce that. So we did a big analysis looking at what causes no-shows, at least at CHN, although I think these results are pretty externalizable. The biggest cause was the patient's individual history of having no-showed to an appointment. So for somebody who no-showed, 41% of their previous experiences, they were more than 3 times as likely to no-show at their next visit. And you may know that on Epic, you can actually see in the schedule a patient's individual no-show history. And so that enabled us to predict who was less likely to no-show and where we could intervene or who we could overbook. The other big predictors were appointment with an empaneled provider. So somebody who was getting squeezed in with somebody other than their regular doctor was 3 times more likely to not show up. Patient age, patients who were 19 to 29 years old were twice as likely not to show up. The appointment type, so people were less likely to show up for their first visit or for a regular sort of follow-up, more likely to show up for an annual. And then lead time. A GMA, if we book more than 30 days out, we have something like a 40% no-show rate. Things that I always thought about, like the time of the day of the appointment or the season of the appointment, had a small effect size, but were still statistically significant. Time of the month, which I always assumed was a big predictor, turned out not to be statistically significant at all. So when we know this, what can we do about it? And we were just embarking on a project to use some behavioral economics, which is rooted in social psychology, to figure out, is there a way to change people's behavior around no-shows? So this is sort of the generic reminder that people get, right? Like you have an appointment with Dr. Weissman on Tuesday at 8. So the question is, if we change the nature of those reminder calls, is there something that would actually impact people? So for example, loss aversion says people don't want to spend more time on the waiting list. So if the reminder said, you have an appointment with Dr. Weissman, if you miss this appointment, the next you would drop down to the 100th person in line for an appointment. Is there temporal discounting? If you tell people, coming in and seeing Dr. Weissman next week reduces your chance of more serious illness. Or, some warning that if you miss this appointment, the next appointment is 2 months from now. Then there's a look at social norms. If you tell people 80% of people are going to keep their appointment, don't you want to be one of those 80%? Does that change how people think about what they're doing? Because obviously they have no way of knowing that. And then there were questions about, like, if you added on some additional information, you could go shopping at the supermarket that's right next door when you come. There's babysitting in the basement. I can help you with directions or subway directions if you, clicked on a number. So this is just beginning to look at some of these things, but it is an interesting way to think through a lot of the stuff that we've been doing historically. And is that really, is that getting the results that we want? Empanelment we talked about, and we were shocked to find out that a lot of our patients at CHN were not getting seen with their regular doctor because they were begging for a sooner appointment or needed to be squeezed in. So we went through and really looked at, who the most frequent provider was, who did their most recent physical, and who, if they hadn't had a recent physical, who saw them recently, period. Hopefully it wasn't this like way too general practitioner who says, could be anything. And then we assign people, formally we're using eClinicalWorks, to be the PCG in eClinicalWorks so that we could really track and really make sure that the call center was directing people the right way. And we found, sort of early on, we were able to get from about a 24% continuity rate to sort of 57% at the peak, and then it flattened out a little bit. We have a similar model, similar but different model here, especially among the primary care docs. This is tied more into measuring quality metrics and panel size. And it really lets people share patients so that we can have teams who cover for each other, and people can share patients on a panel. But same idea: get people impaneled and keep them seeing the provider that they normally see. So DISRIP is almost over. For a long time, I couldn't even go to a meeting without talking about the New York State Delivery System Reform Incentive Payment Program. But this is really the source of a lot of the funding for a lot of these kinds of look at what we're doing and why we're doing it and how we're doing it. So just as a reminder, DISRIP is this like $8 billion program that came out of Medicaid redesign. And the goal was really to reduce ER visits and hospitalizations by about 25%. Mount Sinai, of course, created a big performing provider system with a big nexus of productivity up on the Upper West Side, but really throughout Manhattan, Queens, and Brooklyn. CHN was a proud partner. We have about 200 partners throughout the city, which covers about 4,000 programs and about 5,000 doctors. At the beginning of DISRIP, the goal was really setting up all these kinds of things that we could do. And then as the years have gone by, focusing more on actual outcome metrics and less on the process metrics. It's another way of looking at it. So here we are in the middle of the 5th year of the program. Where's my pointer? Middle of the 5th year of the program, which is when this is all supposed to end next March. And then, although there were calls, there was an article yesterday in Cranes, there have been some calls to extend funding for a couple more years. So a lot of the programs that DISRIP set up were around things like improving screening, improving care of chronic illness, looking at high utilizers. And that led to a long list of specific programs, some of which we'll talk about in the next section, and most of which I'm hoping are going to continue even as the formal DISRIP funding sunsets over the next few months. So this is when I take a sip of my tea and we talk about the changing nature of specialty care. So this was our workflow, more or less. This came out of a New England Journal article by the folks who run Rubicon. But this was very similar to what life looked like at CHN when I, as a primary care doctor, wanted to send a patient to one of you fine specialists here at St. Luke's and West. And, I would write a referral in ECW. Some clerical staff would translate that into a referral system. They would usually call, depending on the practice, either put it in a different system or fax it over or call, schedule an appointment or help the office schedule an appointment. Somebody would then contact the patient and let them know when their appointment was. It was often weeks and weeks out. And then the patient would go or not go. Lots of times they missed. We don't have good data, but we think that about 60 or 70% of our patients actually missed that first subspecialty appointment. When they did go, a lot of times, because we were operating out of different EMRs, a lot of times they wouldn't have the lab data or imaging data available. And they would tell the patient, look, we'll just do it all again today, and you can come back in a month, and we'll see you again. And then this whole process would start all over again. Obviously not ideal. So there are a bunch of solutions to try to make this better. One, ReferWell was actually started by a cardiologist here in the Sinai system. And it's basically like OpenTable for restaurant reservations, except this is for primary care doctors to pick specialists. You can, in our case, it merged with the ECW data. So we knew instantly which insurances the patient had, which insurances the specialist took. If the specialists were signed up for the premium service, their available times would show up, and you could click, the patient would get a text to their phone with a map and a confirmation, and they would get a printout that had more information. And the specialist office would already have all the demographics and the insurance information without anybody having to make a call and read it out and transcribe it down. When it worked, it was great, and it brought our specialist show rate, the show rate, from 30% to like 75%. So it's a big help. Not a lot of people were signed up for it. There's some other glitches, but overall when it worked well. At Sinai, you may know we use a sort of competitor called Pareto, which does a lot of similar things. Although operating more in the background here, doesn't have all the specialist schedules and insurance up to date quite the same way. Oops. And I'll just click out of it. So another option is to not have the patients go see the doctor in the office at all. We've been rolling out video visits at Beth Israel. I just did my 4th or 5th or something this week. That's me sitting at my desk doing a video visit with my iPhone on this little stand and Epic open over here. And this is what it's supposed to look like in this demo. I don't know why they have this patient like sitting in front of a shower curtain or something. But the idea is the patient and you can see each other and yourself. You can document on Epic on the side. And it's been a real hit. I mean, it's obviously not for every patient. It's not for every disease process. But it does save the patients a lot of hassle of taking time off of work and coming into the office. It saves me a lot of time because the patients are sort of logged in and ready before I log in. And the visits tend to be a little more shorter and focused. They're billable just like any office visit is billable. And they've been a real success throughout the system, but just speaking from personal experience, they've been a real success in that way. And patients like them. And I think this is an article that came out in JAMA last November. I think traditionally people have thought about telemedicine as this solution for rural areas where there weren't specialists available. But the success rate in large commercially insured urban populations has also been demonstrated. And so I think there's a real interest, and I talk about it with patients all the time, a real interest in, in adding this to our armamentarium when it comes to thinking about how to talk to patients. And we can talk about this in the Q&A at the end if you want. I mean, sometimes there's pushback. People feel like it's not a real visit in some ways. And again, it's like one option for people. I think about it a lot for sort of urgent visits. Somebody calls me and they have a cough or a rash or a something, and I call them back at 5:30 or 6, and it's too late to bring them into the office that day. It's a great opportunity to do a video visit and at least get to eyeball them and see how they look compared to just trying to, get a sense over the phone or making them go somewhere to get seen by somebody else. Telemedicine exists in a few other realms at Sinai. This is VC, which is a Sinai-approved telemedicine resource. We're using it in the emergency room, the pediatric emergency room at Beth Israel, because we have pediatricians on staff, or pediatric ED trained folks on staff all night. And so when people go to other emergency rooms in the system and don't know if a patient needs to be transferred either to our peds obs or to the peds inpatient floor uptown, they can do a video consult with our pediatric ED folks and help make that determination. It's been incredibly successful because it saved people some people have been able to go home after the pediatrician sees them, but certainly it saves people getting like transferred twice or transferred just to get sent home or something like that. They're also using VC for community paramedicine. You may have read about this. So this is a program where specially trained paramedics are going out into the community in response, not exactly to a 911 call, but something in a semi-emergent situation. They're able to administer medicines, either the patient's own medicine or a small amount of medicine that they bring with them, and to do some additional diagnostic testing like 12 lead EKGs, stay with the patient up to, I think, an hour or 90 minutes. They do a video consult through VC, either with the primary care doctor or specialist if they're signed up, and with a specially trained emergency room doc. And then they together make a decision about whether there's additional care that needs to be done, whether the patient needs to come into the emergency room, or whether they can stay at home and follow up with the doctor, the next day. And you can imagine for a bunch of asthma exacerbations or fluid overload or things like that, being able to get a 12 lead, being able to give some Lasix or some albuterol and watching them for an hour could save a lot of emergency room visits. Quick shout out to the Maven Project, which is a nonprofit up in Boston. They take volunteer doctors, mostly retired or semi-retired doctors, who then volunteer to do some of these sort of curbside consults or mentoring with junior clinicians throughout the country, specifically in underserved areas. It's a great way for people to use their knowledge and really help facilitate specialty level care in communities where otherwise it's difficult or impossible, either from an insurance point of view or a travel point of view, to get specialty care in a timely way. So those are some of the challenges we saw with the, with sending a patient to an actual specialist, right? Long wait time, fragmented communication where the patient says, I don't even know why I'm here, high no-show rates. We were sending at CHN about 55 or 60 endocrinology consults a month, mostly for diabetes and thyroid, and they were getting on this perpetual wheel of no showing for their appointment and getting rescheduled, and wasn't helping anybody. It wasn't helping the endocrinologists whose schedules were clogged. It wasn't helping the patients. And so, the natural workaround historically had been this like curbside consult where you call somebody you know or somebody from medical school and you ask them a bunch of questions and they give you some best guess based on incomplete history and no physical exam. And obviously that turns into a malpractice nightmare, but also a patient care nightmare. And so we've been trying to eliminate that. We also replaced our tin cans with internet-based phones. And Ron Tamler and a bunch of other folks uptown have created these Epic-based e-consults. So these are asynchronous specialty consults, mostly for primary care docs, but other specialists can use them. So, I can ask a specific question through Epic. The question goes to the specialist. They have 3 days to answer. They can look through my question, but also my clinical notes and all the other clinical history that exists in Epic, in eClinicalWorks, and Prism, and whatever other systems we've used. And then they can recommend either a course of action, or I need more information, or I really need to see that patient. And if they do need to see the patient, they can help expedite either an urgent appointment or a regular appointment. And I can't tell you how many times this has been helpful to me. I mean, I think about a patient I had who had a thyroid nodule that I was going to send for further evaluation. When I sent the e-consult, the endocrinologist was able to query some old St. Luke's database and find that the person had an thyroid ultrasound 6 or 7 years ago. It looked exactly the same. No biopsy needed, no further workup needed. No specialist visit needed. And we were able to save that, in 5 minutes of the specialist time. So easy to order. They're accessible throughout the system for certain groups of patients. Easy to order through Epic. You can order, type eCons in the box. For our F2HC partners, for CHN and Ryan and IFH, they have this through the web-based Epic. Tons of specialties available, more coming soon. And Medicare is changing the rules so that in July, this will be a billable service both for the primary care doc for entering the data and for the specialist for reviewing the data and offering a solution. So these are a little bit old data, but the new trends are all the same. I mean, the vast majority so far have come from IMA Uptown, but also a fair number from visiting docs from Queens, and then from all of the FQHC partners. In endocrine, it's about a third thyroid, a third diabetes, and a third everything else. Volume has steadily increased over time, right through Q1, where it seems like it's finally taken off. And what's shocking is that in endocrine, 90% of the e-consults, 90% did not result in an in-person visit. So only 10% of the time did the endocrinologist say that they actually needed to see the patient. We've also rolled out at a bunch of the practice is Rubicon MD, which I hinted at before. This is a for-profit, independent e-consult service that basically takes anonymous doctors, mostly from big hospitals like the Brigham and UCSF. It has a very simple web-based form that I don't think I included, where you can type whatever information you want. It all gets anonymized, and the specialist then reports back what they would do in a sort of similar situation. There are pros and cons of using the Epic one versus Rubicon. Epic, it's nice because they can review the Epic chart and the other charts, and because you know who the specialist is and you can call them with follow-up questions. Rubicon has a much larger bench, a much deeper bench of specialists. It's a very easy to use web interface. They now give CME credits for reading the e-consult, because just like with our Epic consults, they're meant to be educational, so that after the third time you ask about a thyroid nodule, maybe you'll internalize what the screening guidelines are. And the other advantage of Epic is if somebody does need an in-person visit or needs some specific workup before an in-person visit, Epic can direct that a lot better than Rubicon. So we are trying now to figure out whether we can use some of this on the inpatient side. You have to remember that at Beth Israel, the outpatient practice in Union Square is about a 10-minute walk from the inpatient hospital, and even after the inpatient hospital moves. And so having specialists, going back and forth is incredibly inconvenient. So if we can replace some of that in some way with VC doing teleconsults on the inpatient side, or e-consults with a more rapid turnaround on the inpatient side, and this is all sort of in the pre-planning stage, but figuring out how to be able to build that into a specialist outpatient workflow so they have time blocked out to be able to do some inpatient thinking might bring sooner answers to the inpatient hospital team and save the specialists from having to go back and forth. In all our outpatient practices, we've rolled out technology to see what patients think. I mentioned that patients love the Epic video visits. They really like the e-consults when I can call them back and say, hey, I saved you a trip next month. I went over this with one of our diabetologists, and this is what they think we should do. And we've now been querying our patients. These data are from when we rolled out in 3 of our practices over the last couple of weeks. We've rolled out now to all of our practices, so we can track in real time, basically. People get a text about 10 minutes after they leave the office, and then they can respond back with survey questions and free text comments. So it gives us an opportunity both to intervene on patients who had an unpleasant experience and figure out how to make that right. But then also, as we make real-time changes in video visits or in moving the practice or changing things or changing workflow, we can get pretty close to real-time feedback around whether people have noticed and whether that's making an improvement or not. And this is the timeline for the rest of the construction in Union Square. We've actually made a tremendous amount of progress. We're now here. So we finished the last set of moves. We're just started construction on the specialty suites, and then on the residency practice after that. So we're moving straight ahead, meantime moving on the hospital construction, the psychiatry hospital construction. So many exciting things going on. So thank you for taking this tour with me of a lot of the changes in outpatient care. I hope you too find this as sort of a call to action for bringing joy back to work, for getting rid of all the stupid stuff, making real changes that we can all benefit from. Thank you. I have a few minutes from questions, and I guess both here and at St. Luke's.
That's John.
I'll let Norma go first. All right. We can hear you, I think.
Okay. First, it's a very interesting discussion and with some hope for the future. But I think I remember when I went into practice in the Dark Ages, they said there were 3 A's of practice. First, available. Second was affordable. The third one was affable. So they still pertain because the bottom line for patients is access in a timely way. Just give you an example, because this happens all the time. This is why I think face-to-face is still important, because the less you make the patient the center of the discussion and less of an academic cerebral event with an e-consult, which by the way used to be lunchroom curbside consult, same thing, was that the patient feels that they did not get the full attention to their concerns. The example was a young woman comes in coughing, and she is highly anxious. She practically runs from the waiting room to the examining room and said, "I just want to know if I got lung cancer." I said, "Well, that's a big worry, and let's start from the beginning and find out why you think this way." Anyway, to make a long story short, you can't get there from point A to point B in 10 or 15 minutes. So time is still an important part. Time is now money. So we're physicians being faced with competing demands. That is the need of the individual patient, given their profile, their history, their background, and their current status, and the demands on us to provide the documentation, et cetera, et cetera, et cetera, and still be comprehensive. And I know that the increasing studies have shown in very many publications that the average house officer spends 10% of the time with the patient and 80 to 90% of the time with the computer. That does not seem to fulfill the promise of a need for improved care. So we should address some of them.
Yeah, I mean, that's a great question. Thank you for raising the 3 A's, because I quoted them in a speech on Monday, actually, so I totally agree with you. I think you raise a bunch of interesting points. So let me say this. And I'll try to ignore my echo that's resonating here. So clearly e-consults and video consults aren't the right answer for every case. I think the goal of those is to really reduce the easy ones so that there is more time for doctors to focus on the complicated, not just complicated medical, but complicated interpersonal, as you highlighted. So it's still, it's always a judgment call. It's a judgment call on the primary care doctor's side about sending an e-consult. It's a judgment on the consultant side about whether they need to see this person in practice. And I think you're completely right that the being accessible is really important. And what we found was when we were clogging up the schedule with weren't showing up because they were getting booked so far out, or didn't want to take time off of work, or couldn't, or didn't see the need to, or didn't want to pay another copay, or a million other things, those folks weren't going to the specialist anyway. And meantime, they were filling up the schedule and preventing the person you saw, who you knew needed some sort of specialist intervention, from being able to book a timely appointment. And so by moving some things to e-consult, A, it can decompress the schedule. B, a lot of times the patients love it, because instead of having to take another day off of work or waiting weeks to get an appointment, this afternoon I call them back and say, hey, I just heard back from the specialist and this is what they recommend. And even if what they recommend is you should go see them, they feel good about the fact that this is a necessary appointment, that they're getting whatever workup pre-appointment they need, makes it much more accessible. Same thing with the video visits. I think you can be affable and affordable on video visits and just as accessible. They like it that they can do it from their office, they can do it on lunch break, they can do it, before work starts, whatever, at a time that works for you and for them, without committing to a 45-minute subway ride each way, spending 40 minutes in the waiting room, whatever other stuff they have to deal with along the way. So definitely, to have a 15-minute visit not take 3 hours, I would argue makes people more accessible. And the more we can increase the show rate, the better it is for patients, the better it is for us, the better it is for our workflow, the better it is for our joy of practice. Dr. Angel.
So thanks, Matt. Obviously, I come from Beth Israel, so it's very exciting to hear all the changes down there. I'm sure you saw the editorial in the Times over the weekend about how the business of healthcare is based on exploiting doctors and nurses, especially with their time. And how do you address kind of the physicians with all these things that get added on without a payment yet, because some of them, the payment model will happen later, the RVU model. And so I was at a meeting where now we're gonna, for the 30-day readmissions, they want the doctors to do a 20-minute red cap survey on every patient. And it's just like the doctors at the table were just like, that's kind of ridiculous. And the answer was, well, this is what Sinai won. So how do you deal with those expectations of the doctor?
Yeah, I mean, good question, right? And so many of you have read this editorial in the Times this weekend by Danielle Offrey about how, you know, hospital administrators are preying on the intrinsic ethics of the doctors to not turn patients away. I would argue that a lot of the stuff, I mean, we're by no means done with this work, but I would argue that a lot of the stuff that Sinai is thinking about and that we're doing is really to counter that issue. I mean, I think I can't say enough nice things about the wellness program and the Epic optimization, because it really did find a lot of ways for me to do stuff, you know, save 2 seconds of keystroke 1,000 times a day, and all of a sudden you've saved 2,000 seconds. And a lot of these other, you know, e-consult solutions or teleconsult solutions or smoothing referrals, I think a lot of what I hear the complaints about is like, look, I've got this full schedule that's even overbooked, and now I have this patient who just got discharged from the hospital, and how am I ever going to fit them into this overbooked schedule? And my argument is, yeah, if we can reduce the no-shows and predict who's going to be there and when and where and make them accessible, and we can do that discharge visit by video visit or whatever, we won't be overbooking so many people. We won't have all this unpredictable no-shows, and we won't have this sort of double-edged sword of like trying to cram people into an overfilled schedule, only to find out that like a bunch of people don't show up. And I had yesterday 4 people at between 1 and 1:20. And nobody between like 2 and 3. And the more we can get rid of that, I think the better it will be for all of us.
Really entertaining talk.
Thanks.
How many years do you think it's going to take until we get rid of the doctors completely? No, I'm serious. And create a virtual doctor who is matched to the patient by age and ethnicity and gender and sexual orientation, et cetera, to make the patient comfortable.
So thank you for that question. I don't think that's ever going to happen. I think these are all tools that real life doctors can use to make their care better and more efficient. I'm right in the middle. I was just telling somebody before the talk, right in the middle of The Digital Doctor by Bob Walker, who you may know as a hospitalist, who wrote about this very issue, about how complex medicine is and how complex computers are, and how the interface has sort of changed medicine in some ways for the better, but in a lot of ways for the worse. And I think his argument is it's not going to get rid of doctors, but it's going to get rid of a lot of the stuff that doctors do that's wasteful. And we haven't seen that. You know, obviously, you know, we've all lived through this transition, and we've seen some of the things get better, right? I'm no longer waiting for a chart to come up from medical records. I'm no longer trying to decipher what one of my colleagues wrote whose handwriting I can't recognize. I'm no longer, you know, waiting for some film to come up on the film thing. But, you know, but at the same time, it's added a bunch of other clicks and stuff. And now I think as we figure out how to better use some of those digital resources, there are opportunities for us to use the computer smarter and to replace some stuff that doctors do, but not replace doctors themselves. I think all these solutions require doctors to be on the other end.
I wanted to make a little comment and see what you thought about this. What I see is that there's been an increase in burnout and people leaving practice to go into business and all kinds of other things, even though they're very competent physicians. And I've always thought that not only was it the clerical burden, but it was the shift from doctors owning their own practices and having control of their time and their personnel to the employment model where you have no control of your schedule and you have no control of who's employed by the clinic or how they behave. So what do you think about that? You don't mention that in your burnout.
Yeah, it's a great point. And there's a lot of data about that actually, that loss of autonomy is a big dissatisfier for doctors.
I would say that that's probably as great a problem as the clerical burden. But the clerical burden just became overwhelming the past 10 years. So with all the documentation one has to do to get paid. So I understand that, but number two is probably autonomy.
Right. I agree. I mean, I think, there's a trade-off for autonomy, right? I've worked as an employed doctor my whole career, in part because I could substitute some of the concerns that the self-employed doctors I know, negotiating leases or hiring staff or dealing with payroll and all these things, like I've never had to deal with in that way.
I'm sorry, the worst situation that I generally face in medicine is you start to get into a problem with the patient, you have some data, and then somebody's at the door knocking, saying, you got 3 more people in the waiting room, and you don't have time to finish this. And it's a problem that has some life-threatening potential.
Sure.
And so then what do? You temporize, and that's always a mistake.
So I think, there are many parts to your question. I think you're right. Lack of autonomy is a big dissatisfier, and we try to build in autonomy whenever we can with our practices, when we can, when there are decisions to be made, and we can help the individual docs or the division chiefs make some of those decisions themselves rather than my saying or the hospital saying, like, look, you've got to do it this way. We try to build that in, and we are able to be flexible about some things, and we've been able to push back with the hospital system about the timing of some appointments or the scheduling or the days. We really do try to be open to what the doctors feel like they need. There is clearly some lack of autonomy from coming to work in a big system, but to the extent that we can mitigate it, I think is good. I think there were pressures in the private practice world too, and people were waiting, and there were 3 patients waiting at times because you wanted to see everybody, and people wanted to see you, and I think some of those same challenges exist. Where they come from, it felt different because it was, the doctor saying like, just send Mrs. Jones down, I'll squeeze her in later, feels different than the hospital administrator saying, please see Mrs. Jones at 2:00. But I think some of those same pressures exist, but I agree with you. We need to all find ways to build some more autonomy, even in this complex health system, to build more autonomy into the daily workflow. And we really are trying. I think we have, for example, on Epic, we don't have a standard template for everybody to do a particular kind of visit the same way. Our doctors all develop their own templates. And the downside of that is it's time consuming for everybody to develop their own template. But the upside is they get to practice the way they've been practicing without my saying like, well, this is the only way to see this kind of visit. Not ideal, but I welcome your feedback on that. I think you're absolutely right. St. Luke's. Oh, wait, we got to turn up our volume. Hold on. Hold that thought.
Can you hear me now?
Oh, perfect.
Okay. Well, as a last comment, perhaps, in 1934, Einstein said, when technology interferes with human interrelationships, the world will be full of idiots.
Nice. Well said. And I'm going to argue, I agree. And I'm hoping that these technological solutions will help with human interactions and not replace them.
I haven't done outpatient like a long time now, but one of the things is concierge practice. what is the difference between the patient satisfactions and everything, burnout rate in concierge versus this? And second question was like private, like the specialist practice. A person who has something like surgery, wants or orthopedics, they, in my sense, will definitely finally have some really like bad sprain or ankle issues. I'll go to orthopedics, but like I bypass my medicine doctor. Like, is there some data?
Geez, I don't know the data for either of those questions. I mean, a lot of the concierge practices certainly are using technology and trying to be accessible 24 hours a day through a lot of these things. I don't know anything about the patient satisfaction rates, but I would argue that high quality technology based specialty care should not be reserved for people who can pay money to join a concierge practice. They should be things that we can make accessible to everybody. And I think that's, a lot of what a lot of these technological solutions do is they take the limited pool of specialty resources at the Mount Sinai Health System and anywhere and enable us to take care of more and more patients. Because, an endocrinologist who might spend an hour with a new patient could probably do 10 e-consults in an hour. And so to the extent that their resources are limited, they can provide more timely care to more patients if they can do some of it virtually. Tell me the orthopedics question again. I mean, how do you decide whether to see a primary care doctor?
No, the burnout in the orthopedics, because usually, you would imagine like if somebody really has some like musculoskeletal issue, they will show up. And, the burnout rate in that sense, like how's, depend, I would expect it to be less than the general medicine practices.
Right, I think the burnout rate, if we went back to that slide, the burnout rate for the procedural folks tends to be less. I still think there's a role for a lot of this. There's an emerging literature in physical exam by video visit. The VA has been pioneering a lot of this, especially in the Pacific Northwest, where they have a lot of rural patients and no places to get to. And so they've been doing a lot of work looking at how much physical exam can you do by video. I don't think they focused on orthopedics yet for for obvious reasons. But for example, in neurology, they've spent a lot of time looking at headache follow-ups by video as opposed to in person, and they've been able to replicate a lot of the neurologic exam that way. So I think orthopedics, I think there's potential for all of these things. Okay, great. Thank you, everybody.